So first this afternoon, we have Dr. Suleman, who's visiting from Baltimore from Johns Hopkins. He is an associate professor in the Division of Pediatric Anesthesiology at Johns Hopkins School of Medicine. He's also an adjunct associate professor in the Division of Pulmonary Medicine, or I can't speak, PM&R. He's the founding medical director of the Pediatric Pain Management Program at Kennedy Krieger Rehabilitation Institute. And he's the founding director of an interventional pain management program at Charlotte Bloomberg Children's Hospital, which is only available at 3 centers in the country, so that's really special. And Dr. Suleman's going to be speaking to us today about pain management in complex patients.
Thank you for the introduction, and thank you for Dr. Mia and the team for inviting me for this talk. And I think this is a very important talk to discuss because most of us are not exposed or trained during our residency for this pediatric chronic pain. Some of us have exposure of acute pain, and with the acute pain, if you are treating chronic pain as acute pain, so actually that's more complicated. So it's a good opportunity to understand what is a pediatric chronic pain and how to handle it. And I'm very happy that not only hematology oncology, primary care is also here. And I do these lectures every month to the primary care physician because they are on the front line. They are the one who was dealing pediatric chronic pain. So it's a good to have a little understanding and see how to handle this situation. So no disclosures. So we will talk about understand the pediatric chronic pain mechanism. It's just a quick review. And also I will describe the multidisciplinary pediatric pain program, which I built about 9 years ago at Johns Hopkins and leading this program. And also we will say identify the appropriate pediatric patient for intervention pain management. Definition, we're familiar with this definition, that is the unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. It's also, we define like is electrical signals or message that travel to the brain and all the process in between. But the best definition that pain is whatever the patients say it is and exists whenever the patients say it does. So when the patient come to our clinic, we don't say it's in your head, even if we don't have any evidence, and if we cannot find any imaging or any blood work or anything negative, everything is negative, but still we said, yes, you have a pediatric chronic pain. So let's talk about a little bit quick pain transmission. So anytime when anyone have an injury or any disease process going on, so there is some chemical mediator release, and that chemical mediator actually causing a local inflammation. Because of this local inflammation, the pain receptor gets sensitized, and there's this chemical mediator change into the electrical signals, and then they go from the nerve ending, pain receptor nerve ending, and then it goes to the spinal cord. From spinal cord, it goes to the thalamus, and from thalamus, it goes to the brain. So here is a triggering agent as stimulus, and then it passes through the peripheral nerve and then spinal cord, and it goes to the brain. The reason I'm seeing this picture, because these all the pain signals that go to the pain center in the parietal lobe is passes through the limbic system, the emotion control. So imagine the patient who is feeling this pain signal for a long time, more than 3 months, which is the definition of chronic pain. So this limbic system is continuously stimulated and then can cause mood changes or can develop anxiety. So that is very important when we are dealing this pediatric chronic pain. We need to assess or evaluate, is the patient have some anxiety or depression component or not. In the behavioral psychology or psychiatry, they use a term adjustment disorder with the mixed mood and anxiety, means this is because of this situation, pain situation they develop, or sometimes they have an underlying anxiety or depression, which was never recognized because there's a teenager and there's a teenager behavior, and the parents ignore, oh no, that's fine. So, but when they have developed a chronic pain, and then that pain get amplified. Once the pain signals go to the brain, and the brain stem actually release the endogenous opioids, and that bind to the opioid receptor in the dorsal horn and stop the pain impulse. The reason of showing this slide is these are the opioid receptor in the dorsal column, but these are not the only receptor which can stop this pain signal. So you can see there's several other receptor which can stop the pain signal. So staying on opioids only is not a good decision in the pediatric chronic pain. Yes, if it's an acute pain, patient going through acute pain like any disease process going on, or if they have a surgery or if they have an injury, yes, they can have a narcotics for the short term. But if the acute pain is converted into chronic pain and the patient have, then it's not a good idea to continue the opioids, because that opioids can have addiction component, plus they can make them sedative, and plus they can make them decondition, and plus that can also cause a narcotic hypalgesia. So it's a good idea. So if the patient have a clear picture of the chronic pain, then instead of opioids, then we need to start this non-narcotic pain medication. We know that acute pain is less than 3 months, chronic pain is more than. This is a definition of chronic pain. And in the acute pain setting, we can able to see some evidence, like we have any pathology, any disease process going on, or any injury. So we can see the evidence of the pain. But in the chronic pain, most of the time, if they have like, for example, they are the dancer or cheerleader, they twist the ankle and there's a minor injury. Usually their pain stays for a day or two or maximum a week, but they go away. But in the chronic pain, they continuously feeling a pain, even the healing process is done. The pain is persistent. They come back to the primary care, and the primary care, the imaging, MRI, everything normal. Oh, there's nothing there, but they're still feeling a pain. So that is a chronic pain where we don't see any evidence, but patients still feeling a pain. So in the acute pain, most of the time when we're seeing a kids running around, or they have some minor procedures, they have some pain, and usually that when that healing process done, the pain signals turn off and they start running back to normal. Unfortunately, in the chronic pain, because of this acute pain, if it's a persistent pain, then this make the nervous system hypersensitive, and we use the term central sensitization. When the central sensitization occur, then they are continuously feeling a pain. Even the healing process is done. The signal is continuously firing and sending a signals to the brain, and when that signals goes to the brain gonna stop that kid not to move. And when they don't move, and they become deconditioned, and when they are become deconditioned, now they are not going school, they're not their social life effective, their sports is effective, and now because they are behind, now they start developing anxiety and the depression, and which make things more complicated. Going further to understand the pediatric chronic pain, these are the three definitions important to learn. I'm sure most of you know that, but just a quick review. Plasticity. What is the plasticity? Change in the neural pathway in synapse occur at any level, at the peripheral nerve or at the central or cortical. So these are the neuronal changes can occur during the conversion of acute pain to the chronic pain. How? We're going to learn in next slide. Hypalgesia means the increased pain with the stimulus that normally provoke pain. So I'm pinching my skin here, so I feel a 1 out of 10 pain. But the kids who develop a plasticity or develop a chronic pain or central sensitization, they're going to feel pain 10 out of 10. Allodynia is a pain due to the stimulus that does not normally provoke, like you are just touching and feel the pain, which is touching is zero pain, but that kid gonna feel 10 out of 10 pain. The typical picture is amps. I'm sure you have seen this patient, lots of amps patient, and plus like the complex regional pain syndrome, where sometimes you can see the clinical picture, but the amps you don't have any evidence of anything. So anytime when the patient have a injury, it's called acute pain. And usually, as I said, like they take a few days or weeks, and then the healing process done, and the pain signals turn off, and they're back to normal life. But unfortunately, sometimes during this healing process, depend on the intensity, depend on the history of injuries or the pain experience in the past. If they have a kid, like for example, they're running around, they fell from the in the play area, someone pushed them, they have an injury, but but at continuously having this pain stimulus multiple times, sometimes even the same intensity minor injury can trigger and can activate the central sensitization. And then that small injury, which in the past was not causing a chronic pain, but now this is in. For example, patient coming to the operating room. So I tell my fellows and residents, make sure when the patient wake up in the recovery, they don't have any pain, because might be you are the one who are converting this acute pain into the chronic pain. But unfortunately, all our providers, we are a little bit hesitating because we are not trained to handle this pain medication, either narcotics or non-narcotic pain medication, because we have never exposed to these medication and we are not comfortable to manage this medication, and we always, I will say, we will always undertreat these kids, and because of the undertreat these kids, the pain is not managed, and so they have a persistent pain and they can develop this plasticity, and once they develop a plasticity, then they develop a hyperalgesia and the allodynia, and when they have these features, this means chronic pain. We also use the term central sensitization, which is also is a chronic pain condition where there's no noxious stimulus or inflammation and any damage to the nervous system at the point when you are seeing this patient. So, but what it is an amplification of the neural signal within the CNS that elicit pain hypersensitive. More recently, it become appreciated that in addition to activity-dependent synaptic plasticity, it also can change in the microglia, astrocytes, gap junction, membrane excitability, and genes transcription. All can contribute to maintain this central sensitization. How? We can learn in this slide. So, for example, if the kid have an injury, and when they have an injury, they have these cytokines release. When these cytokines release, actually they activate or cause an inflammation in the non-neural cell, which is called the glial cell. Because of this inflammation in the non-neural cell, that actually make this nerve hypersensitive, and that's not only up to the peripheral nerve, is keep going, and in the spinal cord, that's also activate the microglia, astrocytes, they release these cytokines, and these cytokines actually make the nervous system hypersensitive. So these keep going on unto the brain. So once this patient develop a hypersensitive, it's hard to reverse, but it's possible to reverse. This is another interesting slide which will be helpful to understand how they develop the central sensitization. Patient have a knee injury and is a local inflammation. When they have this local inflammation, actually that's activate and synthesize the pain receptors, and that's sending the signal to the CNS. And this input from the CNS is coming from this source or the wound or inflammation. But if the pain is not controlled, this activity take over by the central nervous system. So now the central nervous system, with the help of input from the wound or inflammation, they are also causing a spontaneous activity of this pain signals. And at one point, this inflammation is almost resolved. Its inflammation is gone, but now the pain was persistent and uncontrolled and untreated, or so that nervous system is now fully taking over this signaling, and they are sending a signals to the brain and all over the brain. Now this is a picture of the amps. Now patients say, I have a knee injury, but now I have a pain all over my body. So that is because of this central nervous system taking over, and they are generating this spontaneous activity and sending the signals to the brain. On the top, if patient is not moving, restricting, because these are kids. So if they feel pain, they don't know what's going on with their body. They're gonna limit their activity. They're not gonna be moved. They're not gonna go to school, and that gonna make more complicated or decondition, and then pain is all over. This is a very important graph for all my presentation, and just pay attention so I can show you why they're feeling this pain with not painful stimulus. So this is a normal graph. So which with this much stimulus, like for example, injury, muscles, or fracture is 10 out of 10. So they will feel this pain response 10 out of 10. But because of the developing a central sensitization, untreated pain, this graph will move to the left. When this graph moves to the left, now with the normal activity, it's not a painful stimulus, it's a normal activity like daily life, walking, running, or these activities, they're gonna feel the same pain 10 out of 10. So that's we are dealing when the patient come to the clinic, we are dealing, this graph is here. And I show this graph to the patient and the family and explain what is the situation going on with this patient. So what we do with this multidisciplinary team, multi-modular approach, we try to bring this graph back to the normal. We are dealing a nerve cell, we are dealing a neurons. That's not the quick thing to resolve, that's not a muscular injury, that is not the bony fracture like you can just in a week or two. So that takes some time to reverse, but again, it's reversible. So now patient develop pain, chronic pain, and now is more than 3 months and is not going away. And now is affecting patient daily life. So mood is changed, sleep is affected. He cannot go walk, he cannot go school, no sports participation, social life is effective, so everything is effective now. And not only this is affecting the kids, it's affecting the whole family. Is the parents cannot able to leave this kid, cannot go to the work, cannot do the things because he's in the pain, so someone needs to be with him all the time. So once that patient develop a chronic pain, so what we need to do, we need to have a multi-modular approach. So pain is complicated biopsychosocial phenomena. We all understand, there was a studies going, there's a lots of literature that it is a biopsychosocial phenomena. And it has three main treatment domain: physical, emotion, and the social, and I will add another one, the functional. So these are the important things to address all these things. If I say the treatment of chronic pain purely on the biological model is more often is effective, no, is not. Is not effective. If I say I'm a pain physician and I can manage the pediatric chronic pain, no, is not my expertise. Because of the biopsychosocial phenomena, I need an input from the behavior psychologist. I need an input from the physical therapist, because we need to look into the whole picture. What are the things are affected? Like, for example, sickle cell patient. He is multiple hospitalization in last like every month or twice a month, and he came. There's no crisis going on, but he have a pain, and so they admitted, do all the test runs and everything. They don't find anything, so this is a pain, purely pain. So they do some pain management, narcotics, and then they send it home because there's nothing going on. But because of this pain process is going through with multiple time, now might be he have a central sensitization, we are not paying attention, plus might be he develop a anxiety or depression because he's a kid, 12 years old, 10 years old, going through with a lot. So he cannot handle it. So might be at this point his anxiety, depression, and plus he's a decondition. He is a deconditioned. He is hospitalized multiple times in the hospital bed, not moving around. Same thing at home, is not moving around. So it's important to have a multidisciplinary team to look into all possible factor which causing or amplifying this chronic pain. So this is the important thing to have this. Oops, sorry. So it's important to the multidisciplinary team to handle the pediatric chronic pain. Honestly, I feel it that the adults should be treated like that. but the kids are sometimes it's hard to give a history, hard to explain how they are feeling. So that's why it's very, very important to have a behavior psychologist to be involved, and they can help to get into dig in. So when I say the multidisciplinary pediatric pain, multidisciplinary pediatric team that we have in the Johns Hopkins or the Kennedy Krieger Institute is a multidisciplinary pediatric pain clinic. This is our frontline team who take the patient and assess, and then we can find out what's going on, what are the factors, and then we plan accordingly. We also provided outpatient therapies like a PT, OT, behavior psychologist. We also have a day program where patients come every day where the outpatient treatment it failed, and now they need a more intensive program where we bring the patient in every day and do the PT, OT, behavior, and the medical management. Sometimes the patient is out of the state, and we have a patient 50% out of the state from California to everywhere. So these are the patients, they cannot come on daily basis, so then we admit that. Or sometime if the patient have a significant functional decline and they cannot be able to walk or they are a wheelchair dependent, then we admit this patient in our rehab program and do the same intense rehabilitation program. We also have a pediatric chronic intervention pain service, which is only few in the country, and we do all the injections where either nerve block or either joints or musculoskeletal injection where we can fix sports injury. So as a pain physician, when I tell anyone I'm a pediatric pain physician, oh, pediatric pain, what, kids have a chronic pain? Yes, kids have a chronic pain. So we deal all these kind of pain, like the chronic pain as a result of injury, surgery, disease, complex regional pain syndrome. 20 to 30% patient we have a complex regional pain syndrome. Conversion disorder. This is, or the functional neurological disorder. This is a very complicated patient. This have all the conversion disorder and the functional neurological disorder patient have a pain, but they have a significant anxiety, depression. So that is, I will say this is not the pain diagnosis, this is more like a behavior or the psychiatric diagnosis. But we open our clinic for them because they deserve a happy life. We want them to help and fix them and back to the normal life. So we start seeing it, but now we actually, one step ahead, we have a FNSD clinic now. So we have all the patient, because it's very overwhelming situation for me to do a psych patient, which I'm still happy to see. But now the leadership understand that they need a little bit more high level of care. So now they build a functional neurological disorder clinic where they see first neurology and psychiatrist, and then they involve me if they need it. We also have an AMPS patient. We also see the physical decondition, hypermobility EDS patient. Yes, might be that patient who have sickle cell patient, might be they have a hypermobility. Is they ever diagnosed? Because the hypermobility is a loose joints continuously having some joints pain which kids cannot explain. And that might be converted into the central sensitization on the top, sickle cell or other injuries or other disease amplify and convert into completely chronic pain. Functional abdominal pain, headaches, migraine, chronic fatigue, PARS, and sickle cell patients. So these are my most common patients I see in the clinic. So when I say the multidisciplinary pediatric pain clinic, so that consists of pediatric pain physician, child psychiatrist, nurse practitioner, pediatric psychologist, pediatric physical therapist, social worker, and clinic nurse, and the coordinator and the scheduler. So child psychiatrist, I added this even when I trained Boston Children's Hospital. They don't have a psychiatrist in the clinic, but because I opened for all the kids who either have a mental health issue, I want to try to help them. So after 1 or 2 years of experience, when I started this program, I realized this is a significant anxiety, depression. They need a medical management. Sending to the psychiatrist is like waiting time is 9 months or 1 year. It's hard to get hold of psychiatrists. So I said, this is delaying the treatment, and this is going to be make things more complicated if we cannot help this patient back to the normal life. So I asked the leadership, which was a very challenging situation, but they agree. Okay, so they say, okay, this is your model gonna be more expensive by adding another MD. I say, well, this is a need. So we bring the psychiatrist in, and if patient need a medication, they start right away on the day one, and that helps. Sometimes we delay the rehabilitation program because the patient have a significant depression and they are not motivated. So that prevent us to bring this patient to the rehabilitation. So we need to optimize their mood so they can go and participate in this rehabilitation program, and to restore their function and help to decrease the pain, and they can go back to the normal life. So when we see the multidisciplinary team, so this is a very unique model, and I'm 100% sure you have not seen this model anywhere. But to having this model, I have to listen my monthly meetup with our leadership, Dr. Suleman. This is very expensive model. This is very expensive model, but I think this is important to help this kid. And with this model, our outcome is really good. I can proudly say we have impossible cases. We bring this back to their normal life. So what it is, so we do an initial evaluation. So we see 2 patients in the morning, and from 8 to 12, which is actually 4 hours. So we have 2 teams. One team is a PT and a pain physician. So they spend 1 hour for a detailed history about their injuries history, about their pain experiences, about their sensory sensitivity. This is another one thing. It was not learned in my fellowship, but I learned in this last 9 years of experience. So most of the kid, if they have some sensory sensitivity issue, like the tag in the clothes, or some kind of food texture, clothing, or heights to the fear to the heights, motion sickness. So if they have some sensory sensitivity, so these kids have a high risk to develop a chronic pain. So we go detailed history, and then we go in a detailed examination from head to toe, because we are a rehab program. So, sorry. So we want to know what their functional level is, and depend on that, then we plan the treatment. So this is a very detailed, and then the team 2 is a psychiatrist, behavior psychologist, and social worker. So they spend another hour or sometimes longer than that, and they try to dig in any stressor at school, any stressor at home. And most of the time we see they have some stressor, or stressor to the sickness. Of course, they are sick for a long time now, they have they stress, they develop anxiety. So, or they have some underlying anxiety or the depression, which actually further get worse. So they spend, once we see both patient by both team, then we meet for a short brief time, and we discuss the highlighted information, and then we swap the patient. And once we done, then both patient, then we sit down on one table and discuss this. So I was told by the leadership, why you cannot see this separately? No, because if you see separately PT behavior, there's always a communication gap. Whatever you don't say everything in your document, right? But when you're sitting, you discuss each and every point, and we come to the conclusion what's going on, what are the factors which causing or amplifying this pain. Once we have this discussion, then we whole team go back to the family or the patient. This is a big whole team sitting in front of the patient, explaining how they develop this chronic pain, and what are the factors which contributing and amplifying this pain, and how we're gonna manage this pain. 99.9% satisfactory rate for this, because previously they have seen a doctors different specialty, 15 minutes, 20 minutes, or max 30 minutes, and they say, oh, I cannot find anything, it's in his head. So that's it. But we said no, she or he have a pain, and that is the reason or the cause of the pain, and that's the way we're gonna manage. And plus we educated, we spent 45 minutes in this conclusion session, and we explain, and from when they heard from each or every expert that this is the thing going on, and we all in the same page, when we explain and we are all saying the same thing, that is more powerful for the family and the patient to understand, we reassure the chronic pain is not dangerous. It's not dangerous as acute pain is, because there's nothing dangerous going on. This is just a sensitivity of your nervous system, which we will calm down with the time and with the multimodular approach. Most of the time they understand and they follow. And plus this kind of a communication and interaction, that actually they build a bonding between us and the patient. Okay, this patient or this team and this physicians and this providers know what's going on with me. So they are the only one who's saying, yes, you have a pain and we have a treatment plan. So that's why they get bounded and then they follow our instruction. So narcotics, as I said, narcotics is a no, we are narcotic-free clinic. We don't, even if the patient is on the narcotics, we do so. Sometimes the sickle cell patient on the narcotics, so we communicate with the hematology oncology team and discuss like you are the one who know is a crisis going on or not. If there is a crisis going on, yes, it's okay to take the narcotic. But if there's no crisis going on, wean off this narcotics and let us handle the non-narcotic pain medication. So we started right away. Most of the time when I see patient not on any neuropathic pain medication. So when I start the neuropathic pain medication and we start the cognitive behavior therapy, physical therapy, that make a huge difference in sickle cell patient. And they have known, like the patient who is going every month in the ER, they have not gone for years back to the ER. So that's actually helped a lot. So as I said, like when they have a patient have a sensory sensitivity issue, if you are treating with the narcotics and keep increasing the dose because they get dependent on that dose and they go up, so that can cause a narcotic hyperalgesia. And when the patient gonna be have an acute process going on or acute pain because of the sickle cell or any other reason, and you are trying to do the narcotics at that point, that's gonna make the more things more complicated. So narcotics is only for acute process and wean off as soon as possible. Yes, it's sometimes difficult because patient is pain, chronic pain. So that is a time when we need to add the neuropathic pain. So that is less requirement of the narcotics and gradually wean. So when we bring in the rehab program over, so our main, we educated, so because you are deconditioned, you are also feeling a pain all over the body. This is because, so we will restore your function first. We will restore your function, we will make you stronger. At the same time, when you are in the pain and trying to move on, you are sending a message to your brain that you can do it. And that helps to retrain the brain. And that helps to change the pain threshold, which gonna go increase and increase, and the slightly pain go. We don't promise that your pain gonna be during the rehab program. Yes, we are trying to minimize it, but still going to be, though, with the time it will get better. But the most important thing is to restore your function and go back to the normal life. We also have an educator in our rehab program. They connect to the schooling. And in the school teacher, they get what's the syllabus they are doing. And we try to do this education session in the during the rehab program. And when we are ready to go back to school, so our educator communicate to the schools and when they explain what the needs is, and if they need a 504 plan, so we help them to get the 504 plan so they can have a little breaks and they can continue to go to the school instead of stop. So other thing is beyond opioids. So if I'm saying no opioids, so how gonna treat? So we have a non-narcotics medication, which most commonly I use Tylenol, NSAIDs, anticonvulsant, neuropathic pain, SSRIs, tricyclic antidepressant, muscle relaxant, local anesthetic, and the patches. Muscle relaxant, some of the pain physician, they do it, but I'm a little bit reluctant because that's gonna make more relaxed muscle. Plus they have some addiction component, so I usually don't do it. But if in an acute setting or something disc herniation related, then I do for short term. So other important thing, as I said, like a dosing. We are not familiar with the dosing, and that is a big issue. We are hesitating either narcotic or any other medication. We also use a small doses or low doses, so that's why patient pain don't get better or patient in the pain for long term and that. So these are some of the Boston Children's Hospital, they published in JAMA for a long time ago. These are the doses that. But again, these are the lower side of the dose. And then we need to, because in adult, they have, okay, 100 milligram Lyrica, just go ahead and start with that. But here we're going to start with a 50 milligram and gradually titrate up to the effect, or if they have any side effect, we stop there and continue that for a few months. These medication, either neuropathic medication, take 4 to 6 weeks to kick in with the appropriate or therapeutic dose. So we explain that to the family that it's not going to be magic pill, it's not going to be relieve your pain right away, it's going to take some time. So these are the other doses that most commonly we use. I'm working on an app, so hopefully we can enter the patient weight and it will calculate the doses for us. And once it will be available on the Apple store free. So other thing is education. That is, most of the kids who come for the chronic pain, their parents are very anxious. Even I'm a pain physician. When I take my sons for the vaccination, I'm panicky too. So I did give a Tylenol, put the patch on, the lidocaine patch, give him iPad. Mommy and daddy take a day off, hug him, showing iPad, and then we use a 25 needle and do the vaccination. That's a nature like parents. So parents, they cannot handle their kids in the pain. So plus the parents' anxiety influence kids' anxiety, and that amplify most of the time. So it's very, very important that educate the parents also. Behavior psychology team, they have a special sessions for the parents. During the rehabilitation, they educate the parents on daily basis. Plus they have a comfortability workshop where they have a one-day workshop where they teach the patients and the parents in a group form. So they teach how to handle this patient, what are the things needs to do and what are the things not to do. So that's very helpful. Outpatient therapies, we provide physical therapy, land, pool therapy, cognitive behavior therapy, feedback by the behavior psychologist. We also do neuropsych evaluation. Sometimes they have a cognitive issue. So if we find by the behavior psychologist and psychiatrist, so we do the neuropsych evaluation. Or if we find something medical related, we send it to the rheumatology, orthopedic, and other also. Intensive daycare with 3 to 4 days per week program, intense program, physical therapy, occupation, and the daily behavior. So that helps. Sometimes they do in a group therapy, like a kind of a boot camp. So all the complex regional pain syndrome or AMPS in a one group, 5 to 6 or sometime more than that. So here we can save some resources, like one PT, one behavior can do this group therapy. And also we have some class time, 1 to 2 hours to catch up so they are not behind in the school. Otherwise, that's going to increase their stress also. Inpatient rehab is also 4 to 6 week therapy, PT, OT, behavior. We do some therapeutic recreational activity to take him to the zoo and other stuff. Child life is involved. Psychiatrists, if they need a continuously management, his anxiety, depression, suicidal ideation, so psychiatrists can continue to follow. The PMNR are the one who are leading the rehab program, but we work closely. Pediatric intervention. So when I tell I'm a pediatric interventionist, so they say, what kind of injection you do in the kids? So they require all kind of injection, epidural steroid injection, facet. So the kids who are a soccer player, they can have a sports injury. Facet SI joint piriformis, very common in cheerleaders and dancer or gymnastic. Muscle joint injection, occipital nerve block for migraine and headache, abdominal block, which is functional abdominal pain. So kids who are in heavy lifting or sick, vomiting, so they sometimes the nerve increasing intra-abdominal pressure actually can irritate the abdominal nerve and patient can feel a localized pinpoint pain. So that can be reversed easily with the tab block or rectus sheath block. Intercostal nerve blocks and and the sternal injection, very commonly done in the hypermobile patient, bursa, scar, and all kind of injection. The thing most important in the intervention, I do all this intervention under sedation. I don't do awake because the area is painful. If you are putting a needle, they are scared. They're going to be traumatized. might be they will move, they can cause more complication. So I do under just a propofol infusion, no gas, no intubation, just make them deep sleep, and I use image guided always so I can pinpoint and target either using ultrasound and the fluoro, and I do this injection. Unfortunately, only a couple of programs who are offering this service. So we still have a time, right? Yeah. So I'm going to discuss one case, so that will give you an idea how we use all our tools to help this kid. So this is a 16-year-old female with the left-sided abdominal pain after a GI some infection, bug infection, and patient have a severe vomiting for 1 month. And later she developed a lower extremities weakness, and now she cannot walk and she is wheelchair dependent. And extensive workup done by the GI team, all the scopes, imaging negative, OBGYN also seen everything negative, psychiatrist also seen, they're seeing some depression, and they try to rule out all the GI, GBS, pelvic inflammatory disease as well. So they cannot, and they have seen more than 20 physicians, and then they finally back to the PCP, and they say what we need to do. So PCP then learn about our program, they send it to our program, and in our program, with a multidisciplinary team, spend 3 to 4 hours and evaluate this patient. And what we find is the patient have a periumbilical abdominal pain 8 or 9 out of 10, and constant and sharp pain. Of course, 8 or 9, 10 patient cannot be functional. So, but patient cannot able to move, cannot move her leg, cannot stand. So we did the neuro examination, and patient was seen by the neuro in the past, and that was a normal examination, and our examination was also sensory motor and reflexes are normal. But when we did the abdominal exam, so we find a Carner sign positive. What the Carner sign is, we asked to try to sit up. When we try to sit up, she have a pain get worse. So it means this is a nerve entrapment in the abdominal wall. So which no one ever pay attention, and everyone just think abdominal pain, and they're just doing a scopes and everything. Patient stressful life, there's a bullies in the school, there was a divorce going on between the parents, patient have a significant anxiety, depression before all this start. So now patient is a homebound, no schooling, completely socially isolated. Sleep is disturbed, they don't have a deep sleep, REM sleep, that's gonna amplify the pain also. Now our final diagnosis with the team is the patient have a nerve entrapment and the central sensitization because of the more than 3 months is for years, and now patient have anxiety, depression, and the convulsion disorder or FNST. So here we need a lot of things to do together. Patient definitely need a rehabilitation, intense inpatient rehabilitation, but the pain is 8 out of 10. She's depressed. Is she motivative? Is she is gonna do this? No, she's not gonna do it. She's even not doing eye contact with us because she don't trust this team or not any medical providers, because no one can fix this patient. So our psychiatrists start the medication for antidepressant. I started the gabapentin right away. And I said, before going to the inpatient rehabilitation, let's do this tab block, and I can see if that helps. So we took this patient to the OR just day before the rehabilitation program, and we did the tab block under sedation, and that significantly her pain is improved, like more than 50%. So that is the big change that she have seen, and she said, okay, I think these team know what's going on. So then there was, we see some motivation. So, and then she was in inpatient rehab for 4 weeks, and after 4 weeks, her function level significantly improved. She can not using a wheelchair, not using a walker, she can walk, and but slow. But we think still she is not fully recovered, so we transfer from inpatient rehab to the day program, where she is coming back and from home, and she do the rehab and going back to, and then we call the STP. So her function level now significantly improved when she ever doing a follow with me. So her function level is significantly improved. She back to the school, social life active. She have a makeup on, well dressed, groomed, smiling face. Sleep was regulated. She's back to normal life. But when I did the examiner, her pain was still a little bit with the palpation or examination, 3 out of 10, not periumbilical, just on the one sided or on the belly button. But she said, no, I'm fine. I'm dealing with this and it's not interfere in my daily life. I said, that small pain can trigger to the 10 out of 10 with any stressful situation. Let me take care of that. So we took her back to the OR and did the injection. Her pain was zero, completely off. Because the pain was zero, so now I start weaning the medication, gabapentin, completely wean off. And I suggest to continue Zoloft and continue to see a psychiatrist because that's going to take more time too. But mood was significantly improved. And but she continued to follow. And Johns Hopkins interviewed her, and she was interviewed for Hopkins magazine because it was a very ideal situation. Thank you. I'm on time.
Thank you, Dr. Suleman. We actually have we're several minutes ahead of time. Does anyone have any questions? Dr. Priola?
So I just have a quick question. We have a couple of children and teenagers that have sickle cell disease in our program that do have that combination of chronic pain. One in particular also has a lot of hyperanalgesia as well, but also has a true sense of pain in the fact that she's got avascular necrosis of her hip, of which no one really wants to truly fix that yet because of her age. So how do you migrate through that process when they're going to continuing to have a true pain source, but at the same time also have all of these overlighting syndromes as well?
It's a very challenging question. Like, it's definitely they have a source of acute pain, which is continually from the hip necrosis. At the same time, sickle cell chronic pain patient. So definitely, orthopedic needs to be involved in that to see what they can do. So, but this patient, definitely we can minimize the patient pain by adding some adjuvants on neuropathic pain medication, by adding a behavioral psychology pain coping skill. I'm sure for this all going through with all these things, anxiety, depression is there. So need to be involved psychiatrists to manage anxiety, depression. Sometimes depend on the necrosis, how severe or bad it is. Sometimes they need a surgery. Sometimes they try to do the steroid injection to see if that can help. So these are the things we can do. But when I joined this Johns Hopkins and my first meeting with the chair of the hematology oncology, and we sit down and we talk and they say, okay, I will happy to see all your patient, either leukemia, either sickle cell, any patient, because their patient need as soon as possible to add the neuropathic pain medication. So, and that we are doing very regularly. And so we have, I would say, like we have a less hospitalization or ER visit with that. So I think this is an important thing, but if you're not missing that chronic part treatment, patient gonna be suffering continuous is that. Answer your question?
Did you have?
I just want to say thank you, Dr. Suleman. I really enjoyed your talk, and just the resources that you have available for these families is just really, truly amazing. Sort of a two-part question. There has been some emerging data about using buprenorphine. Now, I saw your slide with the no narcotics, but it's mostly used for opioid use disorder, but there has been data emerging on using it for chronic pain to minimize the use of short-term opioids, and in sickle cell data, at least, keeping some of the kids out of the hospital. So I just wanted to see sort of what your opinion was on using that medication. The second part of the question is, I know that diet and anti-inflammatory sort of foods and have sort of played a role. I didn't see that a dietitian was part of your team.
Yes.
I wonder if you guys address that as part of your holistic approach.
Yes, we have a nutrition team also. Yes, we have a good resources. We are blessed. And yes, this all nutritional is important. And your first question was, sorry.
It was The medicine called
Morphine, yeah.
buprenorphine. I don't know if you.
So I think that what your thinking process as a sickle cell or hematologist, like you still might be have some sickling or something crisis. So that's why I recommended. But as a chronic pain physician, I strongly say no. That's why I have a discussion with the hematology team. So that you are the one who knows is patient in the crisis or not, right? So I don't know as a chronic pain patient. I look into the lab, but might be I don't interpret correctly. So I say we need a close communication. If patient is on the narcotics and you think there's a patient needs some crisis issue, yes, go ahead and do that, and I will continue my part. But as soon as patient crisis is over and you don't find any evidence, try to wean it, not to continue, because continue with a hypersensitive or central sensitization, he have a high risk to develop the narcotic hyperalgesia. So that's why I said just take it, like keep it for the time when he need a narcotics. Don't give it continuously, because if you giving a continuously, he gonna depend on that dose, and then he gonna ask to increase the dose. And plus, it interfere my treatment as a chronic pain management, because this patient gonna be sleepy, sedated all the time. He's not gonna be move around. But my rehabilitation program is pushing him to walk, pushing him to restore his function level. So with this narcotic, he's going to be deconditioned and he's going to be sedated. So that's why it's interfere my treatment. So that's why we communicate and we say, okay, if we need it, I can take break. Patient don't need a rehab at this point. We will just continue outpatient therapy and continue. And I can help if the patient, for example, I have a scenario, we wean off the patient again back to. This means that my neuropathic pain medication is not helping. So let's change it to something else or increase the dose. So increasing a dose and changing to there's an option, possible some anxiety or anxiety component or depression is not well managed. So let's talk to the psychiatrist and say make the changes in their medication and see if that can help. So in this, most of the time, this is a multifactorial, not the one cause is causing. So we need to address all the factor which causing and amplify the pain.
Thank you.
I know Dr. Harrod has a question. Any other questions in the audience?
Regarding your patients with leukemia lymphoma, do you advocate for prophylactically using the neuropathic meds, or do you
Yes.
wait for the HEMONC team to refer to you?
Very good question. And actually, I will do a presumptive analgesia for the patient who you think he's gonna go through with the multiple procedure. He gonna have a line placement. He gonna have a bone marrow procedures. He gonna have a chemotherapy, radiation purpose. Yes, at this point, if he don't have any pain, he will develop a chronic pain. So let's start the presumptive analgesia and start the non-narcotic pain medication, low dose, and as the pain going up, so that not gonna be a big pain issues if you started presumptively. Yes, it's a good thought. Yeah,
And we have one more question for you.
sure.
Sorry, one last question. A little focused, perhaps, because this pain is so complex and it's multifactorial. But we've had a lot of discussions recently with bone pain in our oncology patients, and we've been using some gabapentin as well as other medications. But one of the questions that seems to come up recurrently is, well, when do we switch if we're trying to escalate gabapentin, but it takes a while to reach a steady state? And do we really like that, or should we just switch to Lyrica? What is your take on like how, because gabapentin has this gigantic
Yes,
dose
yes.
range, it takes forever to get to max dose.
Yeah.
What is your approach when
So,
you think GABA's not working?
Yeah, you're right. So gabapentin is take more time as compared to the other medication, Lyrica, Cymbalta, or TCAs. So and that's actually needs to be go slowly titrating, because if you go faster, that can make confusion, memory issues, sedation, these things. Plus, like FDA warning for suicidal ideation or a suicidal attempt. So that's why it's very carefully titrate. But what I do, yes, I have to go slow because I know the patient, but we are adding other things like cognitive behavior therapy and physical therapy, and also NSAIDs and Tylenol can be if the patient can have that. So, but again, if the insurance only allow us to write the gabapentin. They don't allow us to do for chronic pain Lyrica until they have a diabetic neuropathy or until they have a neuropathic pain, like because of the disc herniation. So sometimes we are in a situation where the gabapentin is not helping or is a slow process, then I have to go and explain the parents that this is a medication, you have to buy it, but we're gonna write a generic name, and that is very cheap, $15 for a 1 month supply by the Giant store. I don't know you guys have a Giant store or not here, but in the Maryland we have a Giant store, and but other pharmacy also actually, if they go for a generic medication, that helps. Cymbalta is a good medication that is, if I see some component of anxiety, then I add it. Sometime actually in a situation where Lyrica is not helping, gabapentin is not helping, then the combination of the medication, like a Cymbalta Lyrica or Cymbalta gabapentin. So when I see the consult in the inpatient, they already, and on some medication. So either I am okay when the patient is in the inpatient, they are under observation, under monitoring, I can go a little bit more aggressively titrating up. But if I'm titrating at home, then I very carefully, because the parents don't know what to do and how to do. So I don't want to be in a situation they have to call 911. So answer your question, like either combination of the drug might be helpful, or either that's why the team evaluation is very, very important, because if you are seeing a patient, you are seeing as a hematologist. If I'm seeing a patient, I'm seeing as a pain physician. So we are missing the component which needs to be addressed: anxiety, depression, deconditioning, all these things. So when you do a team evaluation, so we get everything there. Okay, there's no doubt patient have anxiety, depression, or there's no doubt patient have adjustment disorder because of this situation. So then we address. So that's why multidisciplinary team evaluation is the key for assessment. When you assess correctly, then you have a more option to treat. But if you don't have assess and you're missing other part, you're gonna keep struggling with one drug because that's you do, and then you're gonna end up not helping the patient and making the things more complicated. Okay.
Thank you so much, Dr. Suleman.
Thank you.